Dr. Joshua Kolawole is a lean agile transformational leadership trainer and healthcare quality and patient safety expert. He is a health system consultant, senior healthcare surveyor and assessor with extensive experience in health system strengthening, monitoring and evaluation, institutionalization of quality, and organizational digital transformation. He is a physician and the first Nigerian fellow of the International Society for Quality in Healthcare, Dublin, Ireland in 2014. He has a Master's of Business Administration and an advanced postgraduate diploma in clinical research and quality assurance. Joshua is an inducted member of the Delta Omega Honorary Society in Public Health from the Alpha Chapter, John Hopkins Bloomberg School of Public Health, Baltimore, Maryland, United States, where he obtained his Master of Applied Sciences in Patient Safety and Healthcare Quality, summa cum laude. He is a certified professional in healthcare quality, certified skilled agile framework delivery and project management professional. He has an excellent team spirit, having led teams and worked well in multicultural, multiracial, multi-generational, and rapidly evolving environments. Dr. Josh is a father, husband, coach, mentor, facilitator, speaker, and teacher of healthcare quality and lean agile transformational leadership values and principles. Dr. Joshua Kolawole lives in the United States of America.
All right, thank you so much for joining me today again. It's been an awesome moment, 3 days of great knowledge sharing, learning, and relearning. And I know that as we keep evolving, keep going on, the only thing that can happen is that we'll first transform ourselves, transform our teams, our family members, our community, and then our organization, and then we can transform Africa. How many of us are believers? Do you believe in great ideas? And you believe that it starts with people, few as they will be, who always believe in the impossible. So the manual we're using speaks to transforming the impossible, right? You need to be able to think beyond your immediate environment and see into the future. So today, our topic is adopting quality assurance tools for efficient and effective healthcare service delivery in Africa. I'm going to be taking us through a few slides, and I also have a couple of things to share, tools that I would just like us to see. So I'll make it quick. I have 6 major outlines. I hope we can see better, see it clearly. The first one will talk generally about quality assurance, and quality assurance tool. It will just be a brief talk about that. I'm passionate about quality, and very soon you will see that. And like I said the first time, my goal is to make you start learning better, thinking better, seeing differently, and hearing differently, and then with that you'll be able to analyze, assess your system differently, and with that you'll be able to implement a great change. So analysis of quality assurance tool will be the third one. Then the fourth one, I actually have a case study. I hope we'll be able to do it. There are 3 key questions that I brought. We probably might choose one or go through one of the 3, and if we have like extra time during the break, we can review anyone if you would like. Then challenges of adopting quality assurance tool, we'll talk about that, and then a possible solution to the challenges of adopting a quality assurance tool. So the first thing I want us to note is that quality is never an accident. It's a result of what? High intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. So you notice the example Dr. Shola gave us in the last session. There were 4 options, right? Either of the options could be applicable to different scenario. Do you all agree with me? Could resolve the problem either temporarily or permanently in any scenario. It just depends on whatever scenario you find yourself, and that will determine what you would apply. So, like I said, it's in academics that they give us option A, B, C, D, E, and we're asked to either choose 1 or choose 2 at most, or 3 in some scenarios. But in life gives you, number 1, life will never give you a timetable for a test. I'm sure you know that by now. You may even you are being tested as you're seated right away. Do you understand? So life doesn't pre-announce tests. That's the first thing. So no timetable. So you don't even know, maybe as you're landing in your facility, first thing Monday morning next week, you will eat a test that will demand the context of what you just learned in this, and it might just be in 3 weeks' time. So that's the first thing. You need to know that quality is never an accident. You must be intentional about building a system that drives quality. You must also think about it that it must come out of a sincere effort. If at any point, if your team sees insincerity in the way you're implementing, you're already destroying the ounce of quality. The third thing is it requires a lot of intelligence. It requires a lot of wisdom. It requires you to analyze varying alternatives and then be able to arrive at a final one that you will take that will be applicable to that scenario. So healthcare quality, I will just give us a general definition, refers to the degree to which health services provided to patients meet established standards of excellence and are safe, effective, patient-centered, timely, efficient, and equitable. These 6 words, there's an acronym called STEEP, STEEEP. There is a popular IOM analysis of 6 core dimensions of quality, healthcare quality. So anywhere you see safety, timeliness, effectiveness, efficiency, equitable, and then patients, just know that those are the 6 dimensions of quality that they're trying to refer to. But I still have some more definitions that I want us to share. Quality is doing the right thing, the right time, and doing it better the next time. So quality is doing the right thing right the first time. Are we together? Yeah. So it's not about, we live in a world now where we don't want to put blame on anyone, we don't want to castigate, we don't want to, and it's a just culture. We understand the problems are from system level, not individual level, and all those. But it is better to avoid waste to get things right the first time. Do we all agree? True. Great. So that means we must be really, really intentional about delivering whatever we want to do. We must put in a lot of planning, a lot of intelligent thinking, strategic designs, interventional designs, product design. So we have a lot of things surrounding complexity thinking, design thinking. We must bring all those things into base if we want to implement any program. And remember that when you do it, you must do it despite the resource constraint and to the satisfaction of the community. Can you get something? I've worked in a facility in the United States before where they had to lay people off because of lack of resources. So the first thing that struck me is, I came from Africa. I've seen so many issues of resource constraint. Here I am in the United States again. I still see a lot of being laid off because of there's no project fund. So I came to the unpleasant conclusion that there's nowhere in the world where the resources are unlimited. So everywhere in the world we have resource constraint. So let us stop thinking that the challenge we have in Africa is the challenge of resources. In fact, someone once said the challenge is the challenge of resourcefulness, the capacity to leverage what you have to generate more. So you can use relationship, you can use other forms of funds that are not finance. Money is considered the weakest of all funds, right? I'm sure health, opportunities, positioning, all these things are classified as wealth. So thinking that way, you would understand that in every place you go to, there will be resource constraints. So that's why anytime anyone comes to meet me and says, we have resource constraint, I'm like smiling in my mind, like, don't you expect that? It's norm in this world that we would always have resource constraint. The second definition to quality is the one by the IOM that defines quality as the degree to which health service for individuals or population increase the likelihood of a desired health outcome and are consistent with current professional knowledge. Consistent with current what? Professional knowledge. So we must get it right. Consistent with current professional knowledge. If you are managing malaria with CQ or with quinine in this current time, you may not be consistent with current professional knowledge. That's correct. It doesn't mean the medication might not work, but it just means you're exposing the patient to what? To some adverse events that are associated with this older medication. They've worked, they've saved lives. But with current advancements in knowledge, better medication, better treatment, better advancement in care, we have come to note that if you want a better outcome, you have to align with the current what? Professional knowledge, and that guarantees quality. So at this point, I need you to think through something. Degree to which health service for individual and population increase the likelihood of a desired health outcome. The question is, who is desiring the health outcome? Is it the patient? Is it the provider? Is it the family? Do we understand? So, if I break this down clearly, I need you to process it very well. There is the treatment of the disease. There is the treatment of the person. We've managed some advanced CA patient before, and all they just want to do is they want to die. But we took care of them palliatively to the point that when they were exiting, they said, "You took care of us." Do you understand the difference? Yeah. I'm not saying that you want patient to die. I'm only saying a lot of times we need to be clear about, because the stage of presentation of a patient also matters in healthcare quality. We understand that some patients will not present until very advanced stage, where even healthcare may not be able to help them again. I'm sure you know that, where our current health system may not be able to. But at that point, your goal should move from the treatment of disease to the treatment of the who? Of the person. So you must provide all forms of care to make them as we have hospices in the United States where people are palliatively managed to exit as painless as possible. So let's just understand that holistic, this thing that is embedded in this definition. There are several other analyses or dimensions that we can put into it. Don Berwick said, quality is the degree to which the result of the work you do match the needs you intend to meet. If you miss the need, that's a defect. And therefore, it is not the quality of the mercy you're trying to provide to the patient. It is actually the mercy of quality. It is the fact that the quality system you have put in place is merciful enough to help the person. It's not about you being merciful to want to help the person. Do we understand the difference? I also want us to talk about Avedi's Donobedia. You know, these are fathers of quality in healthcare. So ultimately, he was one who spoke about quality. The secret to quality is love. And I think I referred to this 2 days ago. And I said, you have to love your patient, you have to love your profession, and you have to love your God. In fact, if I were a district, maybe superintendent like Dr. Joe Gracia, I'll probably put something like this as a placard at the front of my facility, all my facilities. So if you're coming here to work, you must love your patient, you must love your profession, and you must love your God. And maybe if God is not allowed in your, maybe you don't want the religious this thing, you can put something else. Love your facility, love whatever. But the idea is there must be element of love in anything we do if you want to achieve what? If you want to achieve quality. Because if it's not based on the passion to drive selflessness, you will really not be able to provide a lot for your patient. So I want us to take a little step back. You know, our concept is about quality assurance too. I just started from quality, then to quality assurance, then to quality assurance too, so that we will get the sequence. Now, if you talk about healthcare quality assurance, I get this definition that if you want to guarantee quality, it is any set of activity or programs that you design to ensure improvement of care. One, by identifying problems and their system-based root causes in your facility. If you don't have the capacity to identify problem, there is a challenge. So the tools we're talking about, and Dr. Shola have taken us through a lot of indicators that we can put on our tools or use our tools to measure. The tools we are talking about must be able to identify problems. That is, it must be able to gather data for us that we must be able to analyze to see what the problems are. So a lot of times we have ocean of data, and I intentionally use the word ocean because we have billions of data around us, but we don't analyze them. Maybe first, we don't even gather them in a very organized fashion, let alone being able to what? Analyze them properly, and then after analysis, then you can even come up with coherent philosophy about what the challenges are and what the advantages you have in your environment are. So sometimes we will have some technical advantages that even we as leaders don't know. So when they tell us analyze data, it's not only about problem. Sometimes it's about seeing your vantage points. Because those vantage points, the awareness of those vantage points will go a long way to even solve some other problems automatically. Number 2 is that quality assurance must be able to help you develop strategic plan and interventional designs. You must be able to think in system, think in concepts, think in frameworks. Because if you don't do that, there's no way you will connect what you're doing with all the other part of the ecosystem where you're working. Number 3 is that your quality assurance team must foster integration by continuous engagement and continuous education. You must be able to create tools that will make you know that, okay, it's time for advocacy visit. Okay, it's time for training and capacity development. You must be able to create tools that would help you adopt implementation science, that will drive improvement, drive innovation, drive transformation. A popular tool like this is the PDCA. Another PDCA, in case you do, is the Plan, Do, Check, Act cycle tool, PDCA, Edward Deming. Another tool is the 6E. I think I spoke about the 6E the other day. There are several other tools like that to drive improvement, innovation, and transformation. The other tool is, there must be tool for monitoring and evaluation. So I promised I was going to show us some. So I tried to open my book, so that the soft copy, so that I can just flip to page, I think 273 when I checked, so that we can flip through it and just see the 2 evaluation model. So scaling up impact is also needed. So anytime we're thinking about quality assurance tools, we must think through them with these 6 eyes. You're thinking through them like, how do I create a tool to identify problem and their system-based root causes? There's a tool for that. How do I create a tool that will help you with strategic planning and interventional design? How do I create a tool that will foster integration? How do I create tool for implementation, create tool for monitoring and evaluation, and create tool for even scaling up impact? So we need health systems that enable the provision of higher quality, safer healthcare that reflects the need of your population. You know, we're having a chit chat, and told me about doing cervical cancer screening for about 200 women. So that means you're sensitive to your environment. But you need to be more active. Why I said that is, as of today, cervical CA may not be the priority. But it's still good. Please go ahead with that. But create a tool to understand what the needs of your society, your population is, and analyze it, rank them. So we've created a tool before that we used in one of my facilities in the United States, where it was used to rank healthcare infection in their order of increasing priority in terms of number of reoccurrence. So at every point, you must also be sensitive, and you must, of course, facilitate better assessment and management of population health. So now, for me to define quality assurance tool, it becomes a more complex thing. So I brought you 2 analysis. Quality assurance tool are software applications, because now we've grown from the generation of just using paper. They are now what? Software, and they don't have to be something big. Microsoft Word is a software. You can just create a table in Word and then use it to create a chart that would help you track everything you want. You could create a table in Word, use it as checklist that will tell you 5 things you must do when you're preparing a patient for surgery. And everything must be filed in the patient folder. So, number 1, maybe payment, check payment. Number 2, ensure that maybe vitals are taken. Laboratory investigation results are all laboratory investigation are being received. Check. So if all those are not complete, then the doctor cannot even start surgery. Do you know that for your aircraft, before your aircraft can take off from the ground, there are checklists they need to mark at every point before they land the same thing? So it's so funny that these things are driven by instructions. I'm sure checklist has helped a lot of surgery, reduce surgical errors and incidences in healthcare. So this is known already. So techniques, charts, frameworks, or methodologies used for analyzing, designing, monitoring, evaluating, and improving the quality of healthcare services. So I want us to understand that quality assurance tool, the goal is about improving the quality of patient care that is delivered in a certain setting. So the fact that I am using a software that is so expensive somewhere where I'm coming from does not mean you have to use a software that is that expensive. So there's a concept popularly known when I was with Farm Access Foundation, where we talk about international standards, local solutions. International what? Standards, local solution. So anywhere you go, just think through that. What's the international standard? How do we adapt local solution? And this is a very simple way to think through it. What exactly is the principle we're trying to adhere with? Once you can understand that, it would help a lot. Now, I've come with my very busy slide, but I just want to help you see the interconnection between what we call an effective and an efficient health system, because it's mentioned in our topic. So the red shows what is connected. You can see integrated care delivery is the same in efficient and effective health system. So an effective health system talks about accessibility, affordability, high quality of care for all individuals, promoting population health, and achieving positive health outcomes in all these 10 points. Efficient health system is talking about how you maximize the quality of care delivered while minimizing the cost, the waste, and the inefficiencies. Anywhere you get efficiency, you're already thinking about minimizing waste. I'm sure you know that. Minimizing cost. So with that, the intertwining points are integrated care delivery, effective use of technology, evidence-based practices, and technology is the same, so patient-centered care, and then continuous quality improvement. But apart from that, you see other things that are also related to each one. But one that struck me more in effective health system is healthcare equity. Because the variance in healthcare delivery across different strata of the society is horrible. The margin is wide, and you will wonder if we're all living in the same world. So some have excellent access to care to the point that some don't even have access to basic medication, and it could be that terrible, even in quote and unquote resource-rich country, if you permit me to use that. We did an outreach to some areas in Dallas-Fort Worth Metroplex. You will be surprised at the abject poverty you would see with people who were born in the country. We call them born with a social security. Do you understand? Yeah. And yet they're living in abject poverty. They've been homeless for years, sleeping beside the road. It could be that terrible. So for some of us living in Africa, we're actually living in a first world country. So I don't want us to use our geographical boundaries and limitations to define ourselves. I want you to know that it's actually a matter of the mind. There are people who are living in a geographical first world country, but they carry a third world mind. And there are people who are living in a geographical third world country, but they carry a first world mind. And I see many of us here in this room as that. So the idea is the quality of the mind that you carry that is the paramount thing. That quality of the mind would cause you to be seen anywhere in the world, either first world, second world, or third world. So I want to help us see clearly the basic 5 types of quality assurance tools that have been implemented at different points in healthcare. Number 1 are the data collection and analysis tools. If you want performance measurement, if you want risk management, if you want to do root cause analysis, if you want data to be visualized on a dashboard, you will definitely need a data collection and analysis tool. I will still list some, so let's chew it one after the other. There's the process improvement and training tools. There are tools for that. And you can see Six Sigma is a popular training methodology, quality improvement methodology. How many of us have heard about Six Sigma before? DMAIC. Define, measure, analyze, improve, and control. Have we heard about it? So Six Sigma is a popular one. I'm a Lean Six Sigma Master Black Belt holder. So I'm licensed to train, like certified to train in Six Sigma. There's the Plan, Do, Check, Act cycle, PDCA, popular, used everywhere. Used by all leadership consultants. PDCA it used to be, I think, it could be PDCA, it could be PDSA. Some people prefer the check, some people say study. So PDC, the C can be check or can be what? Study. And then we have other tools for staff training and education, pre-test, post-test, and all those. We have tools for standardization and for compliance. So we have clinical protocols and guidelines. All the SOPs that they bring for you, National Tuberculosis and Malaria Control Program, guideline, or standard operating, they're actually tools. I'm sure you know that. Yeah. They're actually tools. Now, what I tell people is when they bring those tools to your facility, all you need to do is sit down with them, analyze each of the key modules you need, and bring out indicators like Dr. Shola shared with us that you will use to measure your performance in those indicators. Put those things on an Excel tracker, and I mean on an Excel document, and start tracking them. So you have created a tool from another tool. Now, maybe Excel tracker is even too complex for the area where we are. Can we be sincere with one another? Just get a plain cardboard paper. Draw a line and put module 1. This is the KPI. And rule line, this is what we measured in January, in February, in March. So it does not necessarily have to be, of course, if it's soft copy, we can email it anywhere in the world. If it's hard copy, it becomes much more difficult. Except maybe we'll snap the picture and send it. But I'm just thinking a soft copy is easier to edit and to move with faster. So, but if you don't even have that access to a laptop or a machine, you can just use plain sheet. Just bring out your ruler and rule it out. That's what I was talking about, international standard, local solution. Because don't forget, I said something. The goal in itself is not about measurement. Because as good as measurement is, it has its own limitation. Because if you start tolling only measurement, you will start losing humans. That's where emotional intelligence comes in. That's why I told you, anytime you achieve a result, ask yourself, what have I traded off to get this result? What has been lost to achieve this? Because in life, for anything you do, you're losing something. I'm sure you know the concept of opportunity cost in economics. Our time. Communication and collaboration tools. Incident reporting system, interdepartmental communication channels, patient feedback mechanism that like you was talking earlier. All these are tools. You could decide to make it into a huge database powered tool, and you can decide to just do a paper-based simple tool. The goal is measure accurately, measure data with integrity. I've once gone for an assessment before, and the lab manager knew I was going to check the lab, and I would check for temperature log. So I think while he was with me, he quickly told one of his assistants, go and check if the temperature log is well filled. So the assistant went there and quickly picked a biro. They probably hadn't filled it. I went there in October. They probably hadn't filled it from April. So the guy knew I was going to check temperature log, and the guy just started writing different temperature from April till November. Remember, I went there in October. So he overfilled. so the painful part is not even the whole insincerity concept is actually what got me out of tune. If it's in April and that was the sincere measurement, I'm fine. Let's know that there's a problem, and then we can sincerely work on addressing it. But by trying to use a single biro, remember the ink of a single biro you're using from April should not be the same thing you will use up till October. At least if you were sincere to even record till October. So a lot of different things. So the goal is not about the paper, the tool, the biro, the everything. The goal is about, are we really interested in measurement because of quality? Because we want to improve quality. And then, of course, we can leverage technology and automation tools. That's where we talk about the electronic health record system. I've used quite a number of them. And then clinical decision support systems now integrated with the electronic health record system that even helps clinician gives suggestions about differential diagnosis, treatment protocols for each of the differentials, and so on. And he even suggests the kind of physical examination, investigation, radiologic or laboratory that could be beneficial in differentiating those diagnoses. And then we have several telehealth platforms. And you can use as simple as Zoom. It doesn't have to be something complex, like integrated into your EHR or something. So I'm just trying to demystify everything. Guess what? You can use something as simple as WhatsApp video from one facility to another. So the fact that there's a telehealth platform does not mean it has to be integrated with another, maybe like Epic, a popular EHR in the United States. It doesn't have to be. You can just, I've done facilitation here in Africa before, where we created a WhatsApp group for everyone. We share what the protocols should be, and now every week each person has to snap the picture of what you have done and post on the group. And I review, if there's a feedback, we go. So at a point, we identify some center of excellence that we're always delivering. So we told them, can you snap what you're doing right, how you're doing your quality meetings and everything, take a picture of your summary, help us share it on the group, and then we start using it to help others to develop their tools better. So they see picture of what has been done in another facility, so it helps them to come up with an idea of how they would do theirs. So just WhatsApp facilitation alone, I know, has changed a lot of healthcare service delivery in Ogun State, Nigeria, in Kwara State, Nigeria. So these are things we've seen happen, and you can leverage them. You can use Telegram, you can use Google Meet, you can use anything, as long as the goal is that you can, of course, see each other or discuss with one another in real time. Now, I will go through some myriad of about 28 tools. And of course, you don't expect me to explain each one, because that means we're not going away from here today. But there's an idea about learning that if you're interested in learning, they should just cause your eyes to, stimulate, cause your eyes to be exposed to it. Once you've heard about the name before, any other day someone else brings it up that can we use this tool, or even you find it online, you will be more interested in, you'll be more curious, right? Unlike something you've not even heard about before. So that's why I painfully created this 20. It's not like I want to punish you, so please forgive me ahead of time. Are we good with that? Yeah. Can I go ahead? I have your permission, right? Okay. So it's no longer my fault, right? You asked for it now. All right, number one, we have the check sheet, which is a popular guide. Check sheet, you just have the things you want to count. Okay, so in my facility, I want to know the number of scalpels, the number of staff, number of different kinds of equipment that I have. So you can create a check sheet for that. It's a popular basic tool. It helps you plan and organize data collection. If you get, and now I put asterisk on some of those tools. Those are the 7 basic tools. I will still talk about it at the end, but it's good to always have this. Number 2 is a survey. Survey just means questionnaire. I'm sure we're all familiar with creating or coming up with a questionnaire. Benchmarking tools. We use that to obtain information performance on comparable organization. I expect you under your district to have comparable facilities, right? Comparable dispensaries, comparable health centers, comparable primary or comprehensive health centers. So please put them beside themselves. And when you have a PHC that is already competing with a bigger health center, then it is already showing a center of excellent potential in that PHC. So you must benchmark. Creativity method, it's used for brainstorming and developing new ideas needed for change. So you have a Kanban board and everybody's brainstorming. But one thing that happens with this method is that people create ideas in 2 ways. Is it a fixed focused method where they are very actively thinking in a room? You can lock people up for a day and get them to brainstorm ideas. But they found out over time that there's also learning by diffuse method, where it is at the point where people just open shower on their head. As that water is running on their head, ideas just start springing up. Has it happened to you before? Where you've been thinking about a problem. It was when you get into the bedroom and water just, for me, it happens a lot. The other thing that happens a lot is when I take a stroll in the evening. And I'm just all alone thinking, brooding about the thing, and ideas just start, after like some 10-15 minutes stroll, and I get into the rhythm of the walk, ideas just start flowing. So take time out, walk through the path, just get a trail and sit under a tree, be calm. If you can keep your heart as quiet as possible, your environment as noiseless as possible, some diffuse ideas come. So I don't want to limit you to just the fixed focus method. Now, flow diagram or chart. This is what I tell people. Anytime there is a problem, especially things that relate to like supply chain, please take the pain to draw a flow diagram. It just simply means where did this drug come from? Okay, let's say our original source is from a wholesaler. The guy gives it to the truck driver, isn't it? The truck driver brings it to the local government. The local government gets it. Now the local government, it should be distributed, right? So the local government gives it to local government driver. The local government driver brings it to our facility. They hand it over to the chief pharmacist. The chief pharmacist will now repack it. And now, before a patient can get it, so look at that chain. Do you know at every part along that flow, disruption can happen? Temperature issues can happen. Anything. So that is how to track a problem. But one thing I notice is people don't want to take the pain of sitting down and just creating that flow. Because if you understood that flow, the patient that comes here that will not go home with anti-malaria tonight. Because you will say, why did you come at night? But the challenge wasn't because the guy came at night. The challenge is because a disruption has happened along your what? Or your work chain. Now we have the causal loop diagram, linkage of process. I won't take too much time on those because it will take our. Then we have the affinity diagram. We use it to organize and summarize qualitative information. Remember I was talking about survey tools the other time, right? By the time I take a lot of survey now, I will get information that's similar, isn't it? Sometimes some people will say high blood pressure, some will call it hypertension. Some will say elevated, you understand? So stuffs like that, you can aggregate them together. Or if I don't want to use symptoms, I can use, some people will say I had headache. Some people will say my head was just disturbing me. You know, similar things like that. You can aggregate them together under a single distance. That's what the tool will help you do. Force field analysis. Now, if you see me pause on a certain tool, it means that tool has asterisk and is actually way, way important. Are we together? So I'm going to pause on cause and effect diagram. It's the fishbone diagram. I don't know. I want to exit this slide and see. Can you still see my screen?
Yeah.
So I want to show you this fishbone diagram. Now this is a fishbone diagram. Look, I will not deceive you. If you want quality improvement sincerely, you must be ready to work with your management team to come up with this tool. And for every problem you find yourself in, do what we call a root cause analysis. If you do a root cause analysis, if you're going to do it well, then pick this tool. It's going to help you. So if you're not going to go with something today in this presentation, what am I already saying? In fact, I don't mind exhausting my time on this tool, but I won't, don't worry. So the problem we're having is at the head, this point, which is the what? Patient fall, resulting in injury. What we notice is that before we get back, a patient had rolled down the bed and had fallen. Or when they are trying to get a patient to go and do laboratory or radiologic investigation, the patient sleeps and falls. Now, a patient that came with something else now has head injury because of fall. A patient now has sprained ankle, sprained wrist, elbow, just because of fall. Fracture, we've had issues of rare, it occurs, but it might be rare, but it happens. And you know, for a patient that is just post-surgery and that is restless and that is not well monitored and the patient gets to fall. So, number one rule is that you need to ask your question, what are the key things that are responsible for this fall? So we divide it into as many things as possible. We first list them down. So if you look at this, you see the issue of patient and the staffing. So the first one, under patient and staffing, we broke it down into no nurse support staff. Number two, inadequate nurse-patient engagement and bedside education. By the time you have a patient on the bed, you need to educate the patient about the risk of fall from the bed. Staff alarm fatigue from patient attention pressure. So the gist is we have alarm system where if a patient needs help, they can press the alarm. Some of us have lightning and alarm system, right? If that's applicable. But sometimes, do you know, the staff nurse is so fatigued that she has attended to several alarms. So when your next alarm is ringing, she's probably not even hearing again. Or she's not even seeing the light again. The noise, or she's already attending to another person when you're raising the alarm on the other side. So unfortunately, some patients who are restless will just proceed and fall. Now you have identified problems under a single area. Now you go to another area, we don't have safety culture. So under that inadequate safety culture, you can break it down the more and say, okay, in-service staff education and awareness for patient fall. Maybe it's low. We can say we don't do fall risk assessment for our patient. So if you just have a patient that's coming out of surgery, you've asked questions about their status and all those things, it helps you to categorize their fall risk and helps you to know how to manage them. The frequency of time to go and check on that kind of patient. So we can talk about machine and equipment, bedside alarm. Now, one beautiful thing about this fishbone, do you know it? It can both be a root cause analysis tool and it can also be used as a tool for profiling solution. The same way I'm listing problem under each area, do you know I can list solution? If you look at my table, I intentionally put some problem and some solution.
Okay.
So look at, I'll give you an example now. Under safety culture, I said in-service staff education and awareness for falls prevention. That's a solution, not a problem, right? Mm-hmm. I can also get to under machine, I say bed alarm not installed. That's a problem. So when I want to do another one, I can turn it to bed alarm needs to be installed. So I can use it to do a root cause analysis and I can use it to propose a visual solution. And that's why I said it's a very good tool that if you will not take anything away from this conference, please, this is a crucial tool that would help you. Of course, you can read more about it online. Google is our friend. So, and I'm still coming back to do something. Let's just continue with our. So you can see me give you, so it's called different names. It's called cause and effect diagram. It's called fishbone diagram. It's called Ishikawa diagram. Kahoru Ishikawa created it. It's a great tool, please. Of course, we have matrix diagram, tree diagram, interrelationship diagram, and then driver diagram. Then the next set of tools, you can see run chart. You can see that the run chart has an asterisk on it. It is used to study variation in data over time to understand the impact of changes on measures. So I noticed that the rate of infection, post-surgical infection in my unit is way high, and I want to reduce it. But you know that such problems don't just go down instantly. They are not problems that come from a single source. So there are multiple things that could happen. So I need to start a run chart. I would have a baseline measurement, and then I'll start tracking it. Maybe if I want to track daily, weekly, monthly, it's just for us to agree. I will show you an example of a run chart soon. Let me run through all this. We have Shewhart. So there's control chart is similar to run chart. I'll tell you the little difference in like 2 slides away from here. We have Pareto chart, and you see that it has an asterisk, so it's important. So it is used to understand and focus on the area of improvement with the greatest impact. Viverdo Pareto's analysis or principle is a very popular 2080. And the rule is simple. Look, if you want to solve 80% of a problem in a facility, if you analyze properly, it's 20% that is causing the problem. It's a sound principle. Occasionally, it could be 10-90, it could be 30-70, but averagely is what? 20-80. You will notice, even amongst, if you have a problem and you want to solve the problem, by the time you write down all the solution ways to solving a problem, you will see that it is either 1 or 2 out of all the options you have written that will solve your big problem. By the time the major one is solved, you see the remaining 20%. Well, it's a food for another day for you to analyze. But I hope you're getting me. So there are so many tools. So Pareto chart is an excellent one. We have the frequency plot. That's your bar, like your histogram chart, which visually just helps people to see that if this bar is taller than this, definitely we're not doing well. And if this bar is going down, that means we're doing well. Now we have scatter plot. It's a scatter diagram. It's an XY, you know, the graphical XY axis. This is really for correlation. You want to find the relationship or association between two variables. In most cases, you have an independent variable, which is on the x-axis, and you have a dependent variable, which is supposed to be on the what? Y-axis. The whole idea is that you want to plot a straight line graph, but occasionally your data will not align perfectly on a straight line alignment. You would have scenarios where you would have a negative relationship between the independent and the dependent variable. I don't want us to go into physics now. I have a tendency to go there. And you have scenarios where you have positive relationship. And so you can take that up to the point of calculating the correlation coefficient, where you have a range between +1 and to 0 to -1. And then the closer you are to +1 determines the strength of your association, and might even be an indicator to causality, but it does not define causality. Okay, so you have a two-way table, planned experimentation. I told you I'm going to punish you, but I'm almost done. So we have the Gantt chart, PERT chart, work breakdown structure. These are project management tools, actually. And then I spoke about the 5 why analysis yesterday, always asking the why, until you get to the finite listing. So basically, this is an A3 tool. I intentionally put this in, and I'm sure we said we're going to share this with the team, right? Okay, great. So I would love to stay like 3 minutes here. Please permit me. You know, Dr. Shola gave us so many indicators for measurement the other time. I'm trying to show you this, that you can use a single chart, a single A3 chart. This is just a PowerPoint slide, though. You can use it to create everything that will be tracking something happening in your whole surgical unit. So don't always think that we need to create multiple separate tools. It will be a single chart like this. So look at on this chart, I have what my background problem statement is. Because if I have a chart like this, it's easy for me to convince my team. Isn't it? Do you agree with me? So I tell them what the background problem is. So let me read out the background problem I found. The 4 related injuries in patients have led to increased patient hospital stay, additional cost of care, and decreased patient experience of care and their quality of life. So by the time I tell that to anybody on my team, and I said the surgical unit of my hospital has recorded a fall rate approximately 5 per 1,000 patient days and 2 injurious fall rates of per 1,000 patient days in the last 12 months. So I've defined the problem in a smart way. That is, in the last 12 months, for every 1,000 patient that is admitted, 5 of them gets to fall. 2 of the 5 that falls and became a major injury. And that is significant. Now, I would now go to the next thing. What's my objective or goal? You know what? I'm addressing my team now. We're in a district meeting, general meeting, and I've created this A3 chart on a Microsoft PowerPoint. So I will try as much as possible to share you this direct PowerPoint so that you can edit it to taste. I've used it to help people in different areas that is not even related to medicine. Can you believe it? I've used this to help church to improve. I want you to know that these are tools that are beyond healthcare. So you can use it to create a chart. I've used it to help someone in school of theology. I've used it to help someone in education. So I just want, these are empowerment that once we get from this conference, it would help us to go ahead and become a solution to every part of our community. So you're not only thinking, even the family, if there's a family issue, you can create a chart like this and start thinking through it. Now, so what's the goal? The goal is to achieve and sustain 70% reduction in fall rate and injurious fall rate per 1,000 patient days in the next 4 months in the unit. So we must always define what we want to reduce, and we must base it on time. Don't forget the SMART definition. We must be specific. It must be what? Measurable. Of course, it must be achievable, realistic, and it must be time-bound. Now, I will now say, who are my stakeholders? I must list the stakeholders. So I have the patient and their family, stakeholder 1. Nurse, manager, and nurses. fall prevention team, hospital leadership, surgeon and resident doctors, operating room nurses, and pharmacists. Because there are some medications that can cause fall. So once you know this patient has high risk of fall, then we have to be careful if we're going to administer a medication that can increase their risk. Do we all agree? Yeah. Now, what are the key metrics that we want to use to measure? I've been using those key metrics in my SMART definition, but it's good to spell them out. Now, I was talking about a run chart the other time, right? On both sides of this, you will see two run charts. This is prior to intervention, this is pre, and this is post intervention. So the run chart would help you to see what has happened 12 months before that made me come to that conclusion. And then it will show what is happening 4 months after we have started the implementation. At each dotted point is actually an indication of a point where we have taken measurement. So I'm putting two run charts on this, but below on the right, on the lower left axis, lower left side of this thing, the same big fishbone diagram that I showed you was the one I brought here. I just minimized it and I brought it here. So on a single sheet that you print and post on your wall, your staff can see so many things. They can see the cause and effect analysis you people did. They can see all the stakeholders. They can see the run chart for measurement. And guess what? You can also put to the right side, you can put intervention plans. What are the things we want to do? How are we prioritizing them? Who is the person that will do it? What's the timeline? And then we can keep going up to the point where we can put a control measure. So this whole table is a Six Sigma table that shows you everything from defining to measurement to analysis to improvement and to controlling. That's monitoring and evaluation. And since we'll be sharing this, and I believe we have a cohort, so in one of the cohorts, we're still going to go over this along the whole of the program. So with that, you would have a copy of this document. I will give you another problem, or you will come up with a problem from your own setting. We will now discuss it together and break it down together and do this. I hope you'll be happy to do that, right? So, and with that, you will be able to solve so many problems with this tool. So, I just listed out these 7 basic quality assurance so that if you won't know any out of the 28 I listed, please prioritize these 7. It will help whatever problem you have in any of your facility or in your personal life. Check sheet, that's the tally sheet. Flow chart or process map. Histogram, or what we call frequency plot. Cause and effect diagram, or what we call Ishikawa diagram or fishbone diagram. Pareto diagram, that's Pareto analysis. Scatter diagram, and then run chart. This would go a long way to help. Now, I told us that we're going to solve a practical healthcare quality problem with our quality assurance mindset, right? I have 3 problems here. I know it's going to be a bit tough to solve this in a short time. So, but what I would do for us is, while we're taking our cohort, we would divide ourselves into 3 groups. We will pick each of this problem, or we can create a problem related to each of this problem from our own facility. We'll just fine-tune it to make it better. But we'll read out maybe the one I love most. I love problem 2 more, or maybe most of the 3. Ineffective primary care for hypertension. Okay, so consider yourself as an exalted chief medical director of a large community-based group practice. In order to appear knowledgeable to your subordinates, you decide to practice medicine 1/2 day per week. Maybe like Dr. Deogresa, you said more administrative work than practicing now, right? Okay, so let's now say you decide to say, okay, at all costs, I will show up in one facility half a day per week, right? During one of your sessions, you notice many of your colleagues hypertensive patient that they've seen had uncontrolled blood pressure. You know, so they've seen them in time past in the last 6 months, but their blood pressure wasn't controlled, and they keep coming back and you keep giving them the same medication. That means something is wrong, isn't it? Leading to you wondering whether your clinic is effectively treating this condition. You know that from a mini sample that you saw. Describe the quality improvement based process of effectively running an hypertensive clinic. Let me read the first one so that you won't say I'm biased, right? You're an administrator of an emergency department. Suddenly, you are started receiving complaints that it takes too long for patients to get through the emergency department. Exactly. The ministry has gotten involved and they are threatening to take over your department unless things improve quickly in places where people are held accountable, right? You are not being offered any additional resource and the ministry doesn't want to hear about crowding the hospital issues. You know that happens really. You can't get extra funding, you can't get extra staff, and you have to solve the problem. I thought we talk about resource constraint, right? These are real issues. But about they just want you to fix your internal problem within the emergency department. Describe how you approach this as a quality improvement professional. The third one, so that we read it out, and then what I would do for us is I'll give us an outline to answer such questions as this. At least once you have the outline, you have an idea. Problem 3, it's non-patient centered care at discharge. You are the chief, most important surgeon in the whole hospital or even in the whole world or in the whole region where you're practicing. Or in the whole Africa. You recently received a letter from one of your patients complaining that he didn't understand how to take his medications after he got home from the hospital. What happened? How did that kind of patient leave the hospital without understanding how they will take post-discharge medication? Something must have happened? Really? You are in shock and looking for someone to blame. Of course, you will be in shock now. There are some letters you will read. Even you will enter some shock. But the idea is not to blame anyone. I'm sure we know that by now. But of course, when you read some things, you will first want to know, how did this happen in your department under your watch? So you want to reach out to this, but please don't blame anyone. Describe an improvement process to prevent these from happening again. So, if you want to be detailed as a quality improvement professional, I have 2 slides that goes over like 12 points or outline that would help you. Number 1 is that you must define the problem. Clear and smart definition of the problem. Number 2 is you must do an assessment of the problem and you must do literature check. Are we together? You must do an assessment, a thorough one, assessment of the problem, and then you must correlate with literature, what you find in literature. Don't forget, quality always asks for what? Current scientific knowledge, professional knowledge. So if you're doing assessment of the problem, it must be consistent with what? The current professional knowledge. Number 3 is that you need to come up with a standardized quality indicator that you want to use to measure the problem. That was when he started giving us indicators, admission rate. There's another popular indicator in the US that we call readmission rate. If your readmission rate increases as a facility, something is wrong. You want to check all those rates, infection rates. So you can even break HAI rate into, you can fine tune it into pneumonia, you can break it down into respiratory tract infection, you can break it down further into upper and lower, you understand those kind of things, calculate them. So once you identify indicators, I need you to also know that there are standardized indicators on different websites that you can actually reach out to and just pick. You don't have to brainstorm too much. Some people had brainstormed many years before us. So if you go to AHRQ website, you will just type AHRQ in Google. It would give you'll find so many indicators there. Now you need to describe how you will get your data and what your data collection method will be. Number 3 is you need to define at what level are we assessing this quality problem. Is it from ministry level or from frontline staff? You know, I told you to do a process map the other time. Some of your problems are not from your end, they are from ministry level. And we talk about dynamics of power on how to go and get problems solved yesterday, right? If you want to solve a problem at those levels. Now, comparison of data with sister hospital or practice or national and international standards. Anytime you have a problem, please take the pain to compare, is this same problem common to, if I'm General Hospital Garki, I should ask, is it the same with General Hospital Gwagwalada? I'm just giving an example. I don't know names of cities here. That's why I used where I'm familiar with. Yeah. I want to compare. I want to see. Because benchmarking is a crucial thing. It would help me learn from the other facility and learn what are my own advantage point and disadvantage point. If we're able to get our mind to the point that it can auto-synthesize, we don't have a problem. Once you can auto-develop an A3, you can convert it to something else some other day. That even we will come back to learn from you. Do you know that can happen?
Yeah.
Do you believe it would happen? Yeah. And then let's make it happen. Now, number 7, who are the key audiences and stakeholders to engage about the problem? You must write it down. And about the improvement. Then final analysis of our findings and representations of our data. Then when we have represented our data, we must now come up with a quality improvement goal. After that, we must list potential ways to achieve the goals. Then we must design a PDSA model for the 2 selected ways to improve. And then we come up with a described M&E model to use to ensure progress. So with this, I don't want to take too much of our time. There are challenges to tool usage in Africa. I know that. These challenges are listed here. If you want to take a picture, you can do that. We have issues with fragmentation of the healthcare system, limited access and inappropriate allocation of financial resources. Maybe technological resources are limited as well. We also have our societal, cultural and language barrier that happens. And then we have our administrative and operational risks too. And don't forget poor social determinant of health. Now, possible solutions. We need to standardize our allocation of resources. There's no two way to that. Commitment to digitally secured and integrated health system. Training and capacity building like conferences like this, year on year, getting ourselves updated. Social education, health post, community health workers engagement. Developing transformational leadership training models in our facility. Public-private partnership with strong regulatory support. So we must work with our leaders at ministry and different agencies. Advocacy and political engagement. We cannot stop that. It has to be continuous. Then we must embrace a lean, agile culture for driving healthcare operation. So our administrative processes, we must check for waste and at different points. Now, if we do that, we will improve patient safety, quality of care, efficiency and productivity. We will save a lot of cost. And then we'll start promoting continuous improvement. So for us to transform our health system, there's a lot for us to do. I've spoken about this. We must think as a leader that wants to transform a system. And we must get our team to also think that way. We must collaborate with our stakeholders. We must develop training and capacity building, tailor solutions to local context. It's critical. We must make sure our decisions are made based on data, not based on persons. They must be data-based decision making as much as possible. Then continuous monitoring and evaluation, and then build a culture of improvement, innovation, and transformation. I brought you the picture of TDACare again because everything rise and fall on leadership. If an hospital is going to make history, if you're going to beat any expectation, it's going to be done by you. Thank you so much.